Buenas noches, distinguidos colegas. El Departamento de Oftalmología del Hospital Nacional Guillermo Almenara les da la bienvenida y agradece su asistencia. Nos sentimos honrados con la presencia de los doctores Steve Charles y José Antonio Roca Fernández, quienes tendrán a su cargo el desarrollo de la presente sesión, siendo el tema trasplante retinal autólogo para el tratamiento de los agujeros maculares refractarios. Good night, distinguished guests, Dr. Steve Charles and Dr. José Antonio Roca Fernández. Thank you for accepting the invitation to this meeting. This night, Dr. Charles will share his experience in the autologous retinal transplant for refractory macular holes. Below, Dr. Victor Alba will introduce us to Dr. Steve Charles.
De Dr. Steve Charles en brindarnos su brillante conferencia acerca de trasplante retinal autólogo. Steve ha visitado por todo el mundo, desde Sudáfrica, Finlandia y New Zealand, pero también ha visitado nuestro país. Gracias al doctor Roca, que es el moderador, conocimos al doctor Steve Charles en 1995 y nuevamente nos visitó en nuestro hospital cuando organizó un curso en el 2008. Y todos conocemos al doctor Chief como un brillante cirujano de Memphis y miembro de retina. Él es un American Board of Ophthalmology, profesor de la Universidad de Memphis, medalla Walker del Club Jules Gonan, y tiene en su haber más de 38,000 vitrectomías, más de 100 patentes, ingeniero mecánico y eléctrico. Y también ha editado un libro que ha sido traducido a muchos idiomas y muchos lo seguimos, acerca de cirugía de vitorretina. Es también director del Instituto de Charles Retina en Memphis y ha recibido una medalla como un médico retinólogo innovador. Steve, este es un regalo de Perú para que te lo lleves, en el cual estamos muy agradecidos por ti, por tus enseñanzas. Este es de un artista peruano. Ya te hablaremos ya. Gracias, y siguiendo con el programa, damos el pase al doctor Charles Conde. Gracias.
Bien, nuestro moderador en esta oportunidad es el doctor José Antonio Roca Fernández, simplemente conocido por nosotros. Él realizó su fellow de retina y vítreo con el profesor Juan Verdaguer en la Universidad de Chile. Fue fellow de retina y vítreo en el Jules Stein Eye Institute de la Universidad de California en Los Ángeles. Fue médico del Instituto de Oftalmología desde el año 1995 hasta el 2005 y consultor del Servicio de Oftalmología del Hospital Nacional Arzobispo Loaiza desde el 2007 hasta el 2018. Director médico del Instituto Ojo Primavera, médico de oftalmólogos Contreras y de la Clínica Ricardo Palma. Es presidente de la Sociedad Peruana de Oftalmología, de la Sociedad Panamericana de Retina Vítreo y del 33º Congreso Panamericano de Oftalmología. Asimismo, es profesor de las universidades Peruano Cayetano Heredia y la Universidad Nacional Federico Villarreal, miembro de la Academia Americana de Oftalmología y la Organización Panamericana de Oftalmología y la Asociación de Cirujanos Americanos de Retina y Vítreo, del Club Jules Gonin, y miembro de honor de la Sociedad Argentina de Retina y Vítreo. Asimismo, miembro correspondiente de la Sociedad Colombiana de Oftalmología y de la Sociedad Argentina de Oftalmología. En su haber tiene 42 papers publicados como autor o coautor en revistas. Les damos la grata bienvenida y le damos el pase al doctor José Antonio Roca.
Muchas gracias, Charles. Muchas gracias, Víctor. Buenas noches con todos. Le agradecemos a toda la gente del Hospital Almenara por haber organizado este webinar con el doctor Steve Charles, ¿no? Por favor, háganme todos llegar sus preguntas por el chat, cosa que cuando terminemos tenemos las preguntas de todos ustedes. Okay, Steve, now we're going to start the webinar with you. So you can start right now. You can start.
Thank you so very much. So let's talk about, let me back up to the first slide. Apologize. There we go. Title slide. Thank you so much for inviting me to speak. I'm going to speak about macular patch graft or autologous retinal graft for large or failed macular holes. The introduction, I think, is very instructive about the way we learn. I will never forget being at the Academy of Ophthalmology when Neil Kelly and Rob Wendell first presented their work on macular hole closure. No less than Dr. Don Gass, Tom Albrecht, Ron Michaels, it's hard to remember each of the people, Robert Mockemer, were all backstage, and they said, who's he? We've never heard of him. This is impossible. The tissue's missing. Macular hole surgery doesn't work. Shoot. Facebook keeps trying to log in. It's so annoying. Gosh, sorry. Doggone it. I've got this problem where Facebook tries to take over. Can you hear me now?
Yes, right now. Okay.
Okay,
Perfect.
sorry.
Oh.
So at any rate, what I apologize for all these problems with the software, but at any rate, 2 years later, after hearing behind stage and maybe even at the podium, the world's experts, Don Gass, etc., these weren't really macular holes. Who's Neil Kelly anyhow? We've never heard of him. And then we all adopted macular hole surgery. And that was a huge change for something that was no alternative treatments. And it started already at 65% success rate and got up to 90. But we all know that sometimes the holes failed, and we know that the largest determinant of failed holes is size. Once you learn how to peel ILM and use Brilliant Blue, and the patient positions properly with the gas bubble, there's still a failure rate, and we all have these. And the larger the hole, the higher the failure rate. So 3.5 years ago at the Veil Vitrectomy Study Club, which is invitation only, Tamer Mahmood, MD, PhD, who's from Duke at the time, presented his work and it happened, as many of these inventions do, serendipitously. He was going to do an ILM patch for a failed macular hole that was operated by somebody else. And the other person had peeled ILM so widely, there wasn't any there. So he said, I've done research on synaptogenesis. I think I'll just cut a piece of retina and put it in the macula and see what happens. And it worked. And the patient got 20/80 vision. Well, at this meeting at the Veil Vitrectomy Study Club, everybody that went to the podium or raised questions, this is impossible, it won't work, it's just, it's no different than fibrin or collagen tissue or platelets, there's no way it's functioning retina, you don't know how to do microperimetry, you don't know what you're talking about. And I said, this guy's an honest guy. Let me sit down and look at his slides with him, his pre and post ops and his video. And I decided he must be right. And that all these other people were doing the same thing that happened in '81 when Neil Kelly and Rob Wendell. So the instruction thing is, even if you've never heard of the guy, even if he's not at a prestigious institution, of course he was at Duke, even if he's not in the Club Jules Gannan or whatever, listen. I might learn something and he might be right. So at any rate, I went home and started doing his technique, and I tried to change it. I didn't like the idea of exchanging liquid perfluorocarbon for silicone oil. I'll talk more about that. So I tried to do the first few with gas. And what happened was the donor side would wrap like an umbrella in a windstorm around the forceps, or the first post-op day, the graft would be on the inferior temporal arcades instead of in the macula. So, but I had this idea that I wanted to oxygenate better than silicone oil does. Many, many years ago, we're talking 40, I put PFO in a bunch of rabbit eyes because I didn't like the fact that silicone oil doesn't support oxygen diffusion very well. But it turns out that you can't leave it in the eye longer than a couple of weeks. But I've been thinking about this problem of oxygenation of the retina, particularly in the diabetics, for a long time. And so I decided that I would, after doing some with his method of direct exchange, that I would leave the PFO in place. I decided, rather than a bunch of statistics, just to list cases, and I circled those: 2040, 2080, 2070, 2080, 2100, 2025. So remarkable vision. These are not visual improvements due to eccentric fixation. These people fixate in the middle of the graph, right in the middle of the graph. So anybody that thinks, oh, it doesn't matter, you can put amniotic membrane, you can put ILM, you can put platelets, doesn't matter. I don't know why people think that it doesn't work. But at any rate, I am 100% convinced that what we're seeing is adaptive synaptogenesis. So let's look at some pictures. Obviously, pre-op on the top, this patient had had 2 previous procedures with ILM peeling and brilliant blue and gas. And here's the graph with proper layering. This patient was 20/40. Here's another patient. And if you look at it, you'll notice the grafts, one, need to be oversized. They will shrink. And our plastic surgeon, Chris Fleming, taught me that. He's a big, facial plastic for tumors, for cancer. And he's constantly doing skin grafts. And he told me, always make the grafts bigger. He said, I'm not a macular surgeon. He said, but they always shrink. He's right. And what's interesting is that there's a plasticity, a remodeling, where they take on a normal shape. So they're on top of the retina, adjacent to the hole. They sort of folded down in the hole, as you see here. But then as time goes on, they conform to the hole, like that first slide I showed. Now in this slide, you can see the donor site superiorly, and a major difference with what I do between what Tamra Mahmood was doing, because he did some work in synaptogenesis. He was interested in the idea that peripheral retina, that the Mueller cells would be retinal cell progenitor cells. So he thought the Mueller cells, well, it turns out that's only been demonstrated in fish, and people have tried and tried to turn Mueller cells into retinal progenitor cells in mammalians, and it simply doesn't work. So I had a different idea. I said, instead of taking peripheral retina, I'm going to take very posterior retina. 2 eyes, actually in the same patient, that had our best results. I don't have pictures of them with me, or in this presentation, were patients that had the incredibly confluent pan-retinal photocoagulation for diabetic retinopathy. And one eye had a 4,000 micron macular hole, and the other eye had 3,000. And I took the graft just infratemporal to the macula, as if and so it was almost a figure of 8 sign. So I literally took tissue 200, 300 microns away from the macula, infratemporal, and moved that into the macula, and both eyes got fantastic vision, 20/50 in one eye, 20/70 in the other eye. These were patients that were Count's fingers pre-op, with less than 2400 vision, because very large, 3 disc diameter macular holes. So if I initially started rather posterior, as you can see here, instead of periphery, and you can see these change shape over time. Here's another one with a superior donor side, and look how good the macula looks. This is microperimetry data. I'm certainly not an expert in this, but our microperimetry data shows that these patients, if they have a good visual outcome, and they don't all have a good visual outcome, but most do, over 80%, that they fixate in the graft. So here's pre-op, and then look at the sequence of events where this thing curled up and then flattened out and got back to 20/30 and 20/40. And this shows you the improved macular function and microperimetry over a year's time. So the remodeling of the tissue and the improvement in function, it takes time, as you can see here. Here's another sequence like that as the graft remodels over time. Another patient. And then I began to do the donor side inferiorly. Now watch this plasticity sequence. Upper left-hand corner was the first post-op day. Lower right-hand corner is the most recent image. So look how this remodeled, or to say it in the way you'd explain it to your children, is that the macula knows what shape it wants to be, and it tries to get that way. So that there's an influence of the pigment epithelium possibly. It's been shown that the pigment epithelium under the macula is vastly different from the pigment epithelium in the equator. It's so, and that's said to be due to the microenvironment. Well, so whether it's adjacent retina cells or it's the RPE or both that influence the graft, the fact is that these even foveate, they take on a normal near normal macular shape and function in many, but not all the patients. So what is the technique I use today? I've done them in 27 gauge, but it's easier with 25 gauge in my opinion. I always stain the donor site so that I can make sure if somehow the graft flips over, which if you do the PFO and the grasping of the graft properly, it won't flip over, but I have had them flip over, and you want to put it in right side up, and you want to put it on the anterior surface of the retina, not underneath the way other people try to do. You got to use valve cannulas. Every time you have PFO in the eye, I use valve cannulas in all cases, but if you don't, the PFO will bubble up and you won't have a good view as fluid leaks out. So that's a bad thing. So I stain to make sure there's sufficient ILM peeling in the graft, and I also stain the donor side, as I said. I always make a bleb. I initially tried to do this without making a bleb, but I've done a lot of work at the NIH in putting induced pluripotential stem cells derived RPE on a biodegradable scaffold under the retina. And to do that, you got to make a bleb or you damage the pigment epithelium and even could cause a bleed from the coral capillaries. So make a bleb, a BSS, with a 38 gauge cannula, and your introduction side of the cannula is a good introduction side for the scissors, and then cut the graft and leave a little tag on the peripheral side, on the distal side, I guess you could say, of the outboard side of the graft. Why? That keeps the graft from floating away or flipping upside down. Then once you put the liquid perfluorocarbon in the eye and flatten the graft back into the donor side before you move it to the recipient side, before you move it to the macula, you can take the ILM forceps and pull just a little bit on that little tag of tissue, a little strand of tissue left behind, and break it. So now you can drag the thing right against the retinal surface. Do not lift it away from the retina. As it's being moved over to the macula under PFO with a full fill of PFO, do not lift it at all. You've got to keep the forceps almost touching the retinal surface. And it's somewhat like spreading out a picnic blanket or making a bed, the way you pull that thing a little bit on one side and a little bit on the other side with the ILM forceps. I say here in this slide that I use diathermy to specific vessels. My best cases were when I did a really good job of picking the site where there weren't any vessels crossing it. But if you can't seem to find a site that doesn't have an arteriole crossing it, just don't make a diathermy all the way around the edge. Then you're going to be transplanting dead tissue. Don't laser it ahead of time or you'll be transplanting dead tissue on the margins. Simply use the diathermy and treat a vessel that's crossing it or right on the edge of it and coagulate it with the diathermy. I use this curved scissors. Although the vertical scissors have the proper orientation, the problem is you can't see the deep blade as well. Then there aren't vertical scissors in this form factor. They're only 23 gauge vertical scissors. So an oversized graft, as I've said several times, is very important. Once you've cut the graft, other than leaving the tag, as I said, you use the Med1 dual bore. Do not use a short needle and inject PFO where it drips down into the back of the eye, making thousands of bubbles. Don't do that. Never do that in any case. Always use the Med1 dual bore and use the flat contact so you can see what you're doing, and put that in the optic nerve cup and make a small bubble. Then keep the tip of the Med1 dual bore right on the surface, the top surface of that PFO bubble as it grows. And so you always make a single bubble that way, every single time. And you can use that very flexible tip of the Med1 dual bore, and you can, if the graft flips over the wrong way, you can flip it back so it's photoreceptor side down. So now that you've cut the graft, you filled the eye with PFO, you take the ILM forceps, as I said, and break that little tab on the back. So now it's a free graft, but it's still in the donor side. Then, as I said, drag it bit by bit. I have done it with 2 pair of forceps, 1 in each hand, and chandelier illumination, but you really don't see as well with a chandelier, and I would discourage that method, and it's harder to coordinate 2 hands, each with a pair of forceps. So it's actually better to do it piecemeal. Pull a little bit on the right side, a little bit on the left side, and just inch it along until it's centered on the macula. Leave the PFO in for a week, but the technique at the end of the case is very important. you've got to have a full fill, an absolutely full fill of PFO. All the way up. People say, oh, what about a half fill? It won't work. You've got to fill it all the way up. And take the infusion cannula where the BSS enters the eye out, and then use the Med 1 to complete pressurizing the eye. So no saline, no infusion fluid is in the eye. You've got a complete fill of PFO. It won't, and over a week's time, it won't cause any problems. I have done over 1,000 cases of leaving PFO in the eye for 2 weeks for inferior retinal detachments and giant breaks, and it simply is not toxic as long as you use the Alcon PFO, the perfluoron. What about graft function? It is absolutely crystal clear, as I said before, that these grafts synaptically connect to retina and function. You can't get 20/40 visual acuity by putting ILM in the macula or platelets or fibrin or anything like that. Some of them actually foveate. So there's no question. I coined this term adaptive synaptogenesis to make the point that there's an adaptive plasticity remodeling process that isn't just structural, it's functional, and that's critical and exciting for many reasons. It gives us hope on outer retinal replacement that we're now doing at the NIH with induced potential derived photoreceptors as well as RPE that we're implanting on a 2-layer biodegradable substrate, and the idea of those incorporating into the retina and connecting and working, it's very, very exciting for outer retinal replacement. So this is a very positive idea that nobody would have believed would happen, and thank you to Tamer Mahmood for getting us started down this path. I do not believe that these are Mueller cell derived retinal progenitor cells, even though that was Tamer's original hypothesis. I do not think you should take the donor site in the mid periphery. You should take the donor site very close to the macula, as close as possible, so there's some cone content. If you look at the distribution of cones in the retina, if you travel even 5 degrees from the macula, there's not very many cones. So more posterior is a good thing. There was a time when I was very skeptical that we could ever do outer retinal replacement because of the work of Robert Mark at the University of Utah. In animal models, he showed that when rods and cones undergo apoptosis from a photoreceptor degeneration and hereditary and inherited retinal disease, that the inner retina in 10 days has a chaotic rewiring function, and there's a glial seal between inner and outer segment. That made me very skeptical about the work we were doing at the NIH in Kapil Bharti's group, actually with Juan Amaral, and that's who I operate with, who is one of your wonderful graduates of your programs in Peru, and my friend. And so at any rate, it turns out if you read Robert Mark's work more carefully and in more detail, he says cones behave similarly to rods in that they tend to, the axons will, if you will, skip over the bipolars and synapse on. That's so even in these profound retinal degenerations in animals, he was able to demonstrate something that's positive with respect to explaining what happens here. This shows you the dendrite retargeting. This comes from Robert Mark's publications. So is there any other evidence? I began to search the literature, and so I won't read these, but there are 3 papers here talking about this idea of ectoptic synaptogenesis in mammalian retina caused about rods dying. So the rods die in these cells, and that there's also outgrowth of bipolar and horizontal cells after experimental retinal detachment, and that was shown by Steve Fisher's group. So there's more and more support. The top paper here was by David Charters at Moorfields, who's done a lot of work on PBR, but he actually showed glial remodeling and neuroplasticity in human retina in PBR. So in short, there's mounting evidence that this isn't just a substrate tissue, that you're actually putting functioning retina there that then connects to the retina and remodels in a functionally positive manner. And there's some other evidence. the slides below are both eyes of a young girl, 30 years old, that was seen in New Orleans at the 2 academic programs with this macular schisis, and she was 2,200 both eyes. He said, you can't fix her. Nothing can be done. She went to New York, and she was presented at Larry Unuzi's conference with the people from Cornell and Columbia there as well at that great conference. And they all said, nothing can be done. 2,200 both eyes. She came to Memphis. I peeled the ILM, put a gas bubble in place. One eye's 20/25, the other eye's 20/30 on 8 or 10 years follow-up. And that isn't because I'm a better surgeon. It's a demonstration of this plasticity, of this remodeling, of this repair phenomenon that is so exciting to me. Now let's shift gears instead of talking about synapses and talk about graft oxygenation. There's no question that silicone oil reduces the graft oxygenation because of the oxygen extraction kinetics. Vitrectomy permanently reduces the viscosity in the vitreous cavity 800-fold, which therefore increases diffusion of oxygen from adjacent retina to the graft, except it doesn't work if there's silicone oil in the eye. So when is the graft most vulnerable? The first post-op week, or as long as silicone oil is present. So why would you take recently grafted tissue and prevent the anterior surface from having oxygen diffusion? That's what happens if you put silicone oil in place. If you use PFO, liquid perfluorocarbon, was developed for in humans and is still utilized for severe chemical pneumonitis with liquid ventilation. They pour it in the lungs and oxygenate it because it carries more oxygen than hemoglobin. And so it works for liquid ventilation. It also has been used in Jehovah's Witnesses and people that religiously can't have a transfusion. It's been used for a blood substitute. So in short, the point of use in PFO isn't positioning, face down versus lay on your back. That's doesn't matter when you're trying to fix somebody's macula. What matters is oxygenation of the graft. So it's crystal clear that you're transplanting into the foveolae vascular zone, and the coral capillaris provides oxygen to the outer layer. But what's going to oxygenate the inner layer if you have silicone oil in place? So fortunately, Tamara Mahmood and others in our original paper on this have converted over to this PFO method that I've advocated. And this kind of makes the point. You want oxygen diffusion from the anterior surface, from adjacent retina, which won't work if there's silicone oil, as well as from the back. Einar Stephenson, who's in the Club Jules is the chair emeritus in Iceland, has done a lot of work and I've gone over all the oxygenation thesis that I have with him, and he's very supportive of this. And there's a quote here from him in one of his papers on retinal oxygenation. In short, it's a diffusion issue. There are some people who made note of the fact that the partial pressure of oxygen goes up by 12 millimeters of mercury permanently when you remove the vitreous. Nancy Ho can't prove that, but they were hung up on ascorbic acid depletion and on infusion fluid, which has nothing to do with it. It is 100% about diffusion, and viscosity is a term in the diffusion equation. So again, PFCs hold 3 times as much oxygen as the human blood. They have a higher oxygen extraction facilities. And so not only do they hold oxygen, to say it a simple way, it's easy for the oxygen to get out. Silicone oil counters that. It hinders oxygen mass transport. So I've done a lot of homework here in the polymer chemistry literature about the difference between perfluorocarbon and oil, which validates this notion that the PFO is carrying oxygen to inner retina. So what are the conclusions? 1, Tamara Mahmood is right. This works. 2, these grafts function. 3, it's very detailed, technique oriented. You've got to pay attention to, don't lift the graft, don't put it in upside down, make it oversized, don't apply laser or diathermy to the outer margins of the graft, and you've got to use this medium-term PFO to provide better oxygenation than silicone oil. And if you do that, I've now done over 50 cases, and we've got a really terrific outcome. One of my best cases I did a week ago was a traumatic 1,500 micron macular hole. he had some improved visual function. It was a huge hole. He had improved visual function literally with the PFO in his eye if he held on the first post-op day. It was very exciting. I did that just last week. So that's all I wanted to present. I want to again thank my friends in Peru for inviting me to speak, and wish you good health and safety from this COVID virus, and invite any of you to come visit us in Memphis if you have a chance. Thank you.
All right, thank you, Steve. Now we have some questions for you.
Sure.
You say that the graph has to be a little bit bigger than the hole, and you just put it over the hole, not inside the hole, not over the hole.
Not inside the hole. You don't want to do that. It'll shrink. I've had 3 or 4 cases, or maybe 5, where I thought it was big enough and it was overlapping the edge of the hole, and now there's a little crescent-shaped gap on the edge, and patients have a little tiny scotoma there. So it's got to be bigger. I don't know why Stano thinks you need to put it underneath like he does his amniotic membrane. There's absolutely no reason for that. And think about this. You can't have rejection. You can't have contamination. It's the patient's own retina. So it's not outside the body. Whereas when you're using amniotic membrane, for one, it costs a lot of money. But for two, there is some finite chance somebody's going to get hepatitis or HIV/AIDS or have an inflammatory response from it. So why not use autologous tissue, which is intrinsically safe, and you cannot have a rejection that way?
Mm-hmm. And the remodeling of the graft starts after you take out the PFO, or isn't that weak?
When the PFO is in there, because it weighs 1.8 times more in silicone, it kind of keeps it flat. I've had 2 of them that the edge lifted up when I took the PFO out, and I had to put a gas bubble in the eye to flatten it back out. Fortunately, I didn't lose the graft, but the remodeling is progressive over months, not a week.
Okay.
But functions at the 3-week visit, I take the PFO out in a week. At the 3-week visit, patients notice improved visual function, but it improves greater when 6 months goes by.
Mm-hmm. Here's a question. If you have any experience using perfluorodecaline instead of perfluorooctane?
The index of refraction, the answer is no, but the index of refraction of perfluorodecaline is almost the same as infusion fluid, and it's very challenging to see the interface. So I stick with perfluorocarbon. I've used it for, many years, I guess, 15 or something for inferior retinal attachments. I don't remember the exact number. I don't have it in my head. Anyhow, I've used it a long time and I'm very comfortable with it, so I stick with it.
Mm-hmm. And what is your usual technique? Also for I think the standard holes, for the 500 holes, for 1,000 holes, or for more than 1,500?
So if the holes are 600 microns or less, I'll always do standard ILM peeling using brilliant blue staining and using the Alcon ILM forceps. I don't use the scrapers of any type or the flex loop. I don't use ICG ever. It's toxic. I use SF6 25%, and I don't do combined phaco because the refractive outcomes are not what Americans expect these days if you do combined phaco. Now, if it's a failed hole that's large, like 600 microns, if I did the primary surgery, so I know the ILM is peeled properly, then, and it's 600 microns, I'm not going to go back try to do that again. I'll do patch graft at that point. So anything 600 microns or larger, I'm going to do a patch graft as a first procedure, whether it's or any re-op that's 600 microns, I'm going to do it. Now, let's say a lot of times people will put in an op note, they peeled the ILM when they didn't. They peeled residual vitreous cortex on the retinal surface, or they peeled an epiretinal membrane and they call it ILM and it isn't. Particularly if they're triamcinolone users instead of brilliant blue. They peel something off, and I've been at many meetings where the video is entitled ILM peeling. One look at the screen and they're peeling vitreous, not ILM. So I don't listen when other people say they peel ILM. I put the brilliant blue and find out if they really did.
Yeah, and sometimes you have to restain, no, again. So
yes, absolutely. And with brilliant blue, you can stain multiple times during the case, unlike ICG because it's not toxic.
Another question is, where is the best place to take the graft? Is you say that it's the closer to the macula, but just outside
I take it just inferior to the infratemporal arcades usually, but I have taken it inside the infratemporal arcades, infratemporal the macula, in that patient that had two eyes with literally confluent PRPs all the way up to the arcades. There was just no place to take it outside the arcades.
Okay. Let me see if you have another. Anybody have another question?
A question, Steve. Hello.
Yes.
Because of the adaptive photoreceptors adaptogenesis, the silicone oil could be contraindicated?
Silicon oil is contraindicated because it doesn't support oxygenation of the graft. It has nothing to do with the adaptive synaptogenesis. It has to do with the oxygenation of the graft. So those are separate issues. So you don't use oil because then the graft isn't oxygenated on its anterior surface from adjacent retina. But in fact, adaptive synaptogenesis is why these work. But that's not related to the silicon oil question.
And you say you take it out in about 1 week.
Yes, sir.
But what if you can leave it 2 weeks or no?
I have no problem with 2 weeks. In fact, I've done that in a couple, and that was just fine. I leave it in 2 weeks on my detachments all the time. And my I never do buckles anymore. I've done 8,000 buckles. I haven't done one in years. You got an infratemporal dialysis. I put the PFO in. If I don't try hard to make a PBD, when I go back in 2 weeks to take the PFO out, the PFO is floated up the posterior vitreous cortex, and I take the vitreous out then.
Right. All right. So, anybody have a question? ¿Alguien tiene una pregunta?
Yeah. Steve, do you advise the site near the macula? What near do you advise? The graft.
I take the graft from just inferior to the infratemporal vessels. So just barely outside the infratemporal vessels. I used to take it above the superior temporal vessels. And the reason I don't do that any longer, the scotoma is then down in there when they're reading down a page in a book. So if you take it inferior, then the scotoma is above fixation, and the patients don't even notice it. All right. Well, thank you everybody for listening, and again, be healthy. Okay.
All right. Thank you very much, Steve, and you also
Take care.
Be safe.
Bye now.
Bye. Bueno, buenas noches con todos. Le dejo ahí a Doris Quiroz, quien va a cerrar la reunión.
Oh, nada, yo solo tengo que decir muchas gracias. Gracias a todos, gracias Tono, ¿verdad? Pasaste por acompañarnos en esta reunión. Gracias a la unidad de retina, que forma parte del Departamento de Oftalmología, por el empeño que le ponen siempre a las clases, a las reuniones y ahora a los webinars. Muchas gracias a todos los presentes y a la Sociedad Peruana de Oftalmología porque nos ha permitido participar con su plataforma. Muchas gracias, buenas noches.
Gracias Doris. Y gracias Charles, y gracias,
Gracias,
Víctor.
Roca, por
Listo.
acompañarnos,
Un
Carlitos.
saludo a todos.
Muchas gracias.
Chao, buenas noches. Chao.